Hello, thank you very much for being here at this first session of Friday morning, in spite of yesterday where we were drinking and we went late to bed. Well, I would like to say that it is an honor to be here next to Sir John, that I admire, and I have read many of his books. So we have the honor of presiding. I have the honor of presiding this session on contradiction and complementarity between accessibility and safety in terms of opioid agonists. So I'm going to ask, first of all, Mr. Yifrah KAMINER to make his presentation on youth drug overdose, the role of suicidal intentionality. I would like to add that in spite of what the program says, Mr. KAMINER is not from Minneapolis. He works at the University of Connecticut. So you have the floor. Over to you.
Comedy open mic, so hopefully here and there it will be appropriate. So I'm swearing, I've never been to Minneapolis, even though they decided that I'm affiliated with it. I heard it's a lovely city. Secondly, again, it's a wonderful conference. I'm grateful to be one of the speakers here. And as an American, I want to tell you that it's very nice to go through a week of craving and detox for McDonald's because there's no McDonald's here. So talking about food addiction, Biarritz is a good place for detox. J'aime la beaucoup. Okay, so now let's get back to the serious material because this is very serious and this is what I call the elephant in the room that we need to address. And this is, it's based on a study that we have conducted and finished last year that just has been published in the journal, Journal of Addiction Medicine, and if people are interested. This is my disclosures. Please buy my books because my kids want me to sell more copies than Harry Potter. So go to Amazon and buy my books. I also write children books, and so it's a lot of fun. Terminology. It's very important to address terminology because when we use the term overdose, it's a lay person term. More accurately, based on medical examiners or the people who are doing the autopsies, and all the study of body fluids and so forth of the deceased, it's important to understand that the term fatal drug intoxication is a good one because it's very general, because individuals have different threshold for overdose. Therefore, this is a more uniform term. When I talk about youth, I talk about people up to age 25, 26, when allegedly the prefrontal cortex is maturing. Although I know some people in the 60s, the prefrontal cortex is still maturing, but this is basically the definition. In terms of suicide, it needs to be very clear that there need to be an intent and also means for implementations, even if it's, so to speak, unsuccessful, but the fact that person has the intent and allegedly thinks he or she that they have the means for completed suicide, it qualifies. Something I didn't know and I've learned a few years ago, and it's important, you need to differentiate between manner of death and cause of death. We usually just talk about cause of death, but manner of death is explains whether it's accidental, intentional, or undetermined. Cause of death is very specific. I mean, you had toxic or lethal pneumonia or road accident or so forth. So it's important to understand this terminology. Okay, we have a problem here, talk about dual diagnosis or co-occurring psychiatric disorders. Of the chicken and the egg controversy, what came first? By the way, this is a children's book that I did not write, but what's sweet about it is the chicken and the egg decided to stop arguing who came first, and they are living together ever after, which is a very nice lesson for kids. So suicide in youth, the picture and the numbers are really grim and very painful. There's been a constant increase since 2007 of suicide. When I say suicide, I mean complete suicide among young people. By the way, depression rates has been growing steadily since the mid-90s. And now actually every fifth adolescent in the United States qualifies for major depressive episode. And about a third of them may develop substance use or substance abuse. As you can see, the situation among young adults or emerging adults is even worse. And the majority of those who attempting or completing suicide, you can trace it back, whether by psychological autopsy or by information, although only 30% of people leave in a suicide note. And co-occurring disorders are hopefully increase the likelihood. And of course, if the substance use disorder and any other kind of psychiatric disorders, one of my colleagues, David Goldstone from Duke University, said that it increases the probability by 2.5. On the other hand, other colleagues of ours said it increases the probability at least tenfold. So that's really huge. Opioids, I don't need to tell you what they are, but you know, we have the new kid in the block, which are the nitazines. It's probably, as I saw from one of the titles here, nitazine to fentanyl is like what fentanyl is for heroin. And we even started to see nitazine use among young people in Connecticut, which is a relatively small state. Fentanyl, again, I'm preaching to the choir, let me move on. You know what it is. And this is some numbers that we have from Connecticut. Again, Connecticut is a small state, 3.6 million people. Between New York and Massachusetts, our School of Medicine is like halfway between New York City to Boston. So the numbers are very small, but they, you know, it's a new thing and it's probably going to keep on growing. Xylazine, another problem that we are having, you know, in addition to fentanyl. So this is what's happening, relatively updated until the end of 2024. Now, another very painful issue that probably we don't hear about it here is that almost close to 2,000 children before the age of 4 died from drug overdose. And you say, oh, mon Dieu, how did it happen, including under the 1 year? Well, they were exposed by the parents in one way or another. And this just was published in Pediatrics, and it breaks our heart to think about it. And I would mention for the first time that I would like to address very briefly. I was hoping there's going to be a symposium about it, but if not now, hopefully very soon, about the benefits of civil commitment of substance users, particularly those who are using fentanyl and also have little children at home, because this is unacceptable. So increased risk for opioid use. Again, earlier age of initiation, psychopathology and other substances being used. This is consistent with finding that those who start using alcohol or cannabis at a very early age definitely have a high likelihood of becoming what used to be called abuse and dependence, having substance use disorder. And even having alcohol use disorder predicted more rapid opioid use disorder. And this is studies that go back to the late 90s by Shirley Hill from the University of Pittsburgh. Now, again, I'm a messenger of terrible news, and here we are, and it's probably 12th now, but I don't have the statistics. So fatal overdose rose sharply among teens, and as you can see, it was 2.4 deaths per 100,000 up to 2019. Then it jumped to almost like doubled. And in 2021, 1 year, guys, 1 year change, it's another 25%. And I don't have all the updated pictures right now, but it's probably not better, even worse. And again, fentanyl was identified in most of them. So adolescents do have access to fentanyl. Now, in terms of suicidal motivation, I'd like to cite the studies done by Hilary Connery and Roger Weiss from McLean Hospital that really inspired my research with young people. And as you can see, they looked at it and found out among survivors of OD that there is some kind of a continuity. It's not binary. It's like a wish to die versus having an intent to die. And as you can see, there is definitely correlation of moderate magnitude, 0.58. And it's really a very important kind of to understand. And I would like to refer you to a couple of papers headed by Hilary Connery and that are more detailed about what they found and what does it look like. Death of despair. This is a growing term that I don't know if you hear it in Europe, but people talk about it more and more in the United States. And as you can see, this is a very recent slide that I made. There is, beside the fact that the United States, unfortunately, is the worst in terms of probability of death by overdose, the area that suffers most is called Appalachia. Appalachia is an area of working class people, especially miners in states like Kentucky, Virginia, West Virginia, all this area. And it's a young people, white people usually 40 to 60, with very low education level, very few prospects at work. People get depressed, people get lonely, people start drinking, using drugs, including opioids, and die early. So it's called death of despair. One of my presentation, which I'm not making here, is talk about the fact that one of the reasons that suicide rates keep on going on among young people in the United States, because we are not paying attention to changes in trends. One of them is if 100,000 people in the United States die every year from drug overdose, how does it affect their children? Wouldn't you expect the children to be anxious, depressed, lost, lonely, hopeless, helpless, suicidal? That's a large chunk of number. There's some other reason and issue that I will not talk about right now because it's not part of my presentation, but there's a lot of issues to think about why things are getting worse and not better. Not to mention my statement, which is that there is an inverse correlation between the progress of technology and mental health conditions in young people. Every kid wants to have iPhone 20 and Galaxy 300, and yet depression rates going up, suicide rate going up. The quickest rising segment of suicide in the population in the United States are girls aged 10 to 14. I've been around for many years. I haven't seen this 10 or 15 years ago. So the times are changing, and not for the better of our children. And I'll stop here, but I want to introduce to you the term death of despair because it's very important. Okay, so what have we done? We conducted a study among methadone maintenance treated young people, which is great because, you know, those who are in methadone maintenance have, or the other way around, those who are not in treatment, the likelihood, the probability of overdosing is 3 to 4 times more, and Dr. Marimani will talk about it. So we studied people who were already in treatment, and we wanted to check the level of depression, the level of severity, overdose behavior, overdose perception, and a couple of other things. And okay, you probably will have difficulties to see this, but the bottom line, these are like a collection of individuals. And remember, 18 to 26, in responding to all the questionnaires that we asked, the point, again, heartbreaking, unbelievable, people up to age of 26, multiple episodes of OD, 3 or even 7, and the people have survived. So this is really very, 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 very bad news. And one of the things a lot of people don't know, and I think it's important to make the public aware, the fact that somebody has been resuscitated and revitalized by naloxone and everybody is happy, naloxone is just a mean to an end. It's not the outcome because, as you know, opioids affect the respiratory center in the medulla oblongata, meaning that those people are victims and casualties of hypoxia. So the same way that you have myocardial infarction because you don't get enough oxygen-saturated blood to the heart muscle, and then there are infarcts, there's brain damage caused to these people as well, and they are very slippery. I'm not saying it as a judgment, but they don't want treatment. You bring them, in the emergency room, they disappeared. So on top of the fact that they don't want treatment, also the cognitive ability is deteriorating. So that's another issue to think about. Should we consider civil commitment, especially to those who are, so to speak, repeat, I don't want to call them offenders because they're judgmental, but repeated victims to their own addiction and to the fact that they are now cognitively impaired. Again, I know it's difficult to see it, but I invite you to, look at PubMed and get the publication that just came out. But the bottom line is that a very high percentage of these kids, or these young people, I call them kids because I'm an old guy, have these problems. And let me just tell you briefly, 42% of the sample had history of suicide attempts. More than 78% had more than one episode of OD, meaning these people are repeaters, and it's going to happen again and again as long as they're using drugs. What else is important? They were younger at the onset of opioid use, not surprising. They were less likely to be Hispanic. When you break it down into ethnic and racial subpopulation, it seemed that Hispanics in the United States are more fortunate to some degree, but I don't know to how long, statistically at least, relatively to those without substance abuse history. The magnitude of intent to die before the most recent OD was predicted by number of lifetime suicide attempts, likelihood that participants thought they would OD before their most recent OD, and the number of days using illicit opioids in the last 30 days. So there's some ways to predict if you have a clinic who are, they're all at high risk, but who is at the highest risk, because we want to know when to be very, very clear that we need to extra intervene to prevent the next event. So this is a slide that I just wrote the night before I came here because I wanted to put it all together very fresh. And again, I'm inviting comments and discussion and maybe future symposium. First of all, it needs to be discussed. We cannot ignore it. Denial and avoidance not going to work. And this is the elephant in the room. So the question is, what are we going to discuss? Particularly when you talk about minors, and even if it's not minors, that we need the family, the parents' consent, young people up to age 25. So yes, there need to be a balance between potential clinical benefits, such as reducing morbidity, mortality, and ethical consideration, clients' autonomy. I work with adolescents, and I hear a lot of time when you discuss with them, they will tell you the last-ditch effort. I'm entitled to make my own decisions. This is my life. And what Dr. KAMINER says, yes, you're right, but not under my watch. So this is our responsibility as adults and grown-up to protect those kids from themselves. It's more difficult when they're over 18 and basically they're considered to be independent adults. Family involvement is very important because of age of legal consent. In the United States, sometimes some states take the liberty of doing all kind of, if you will call it prevention or intervention with young people without their parents knowing about it, and that's definitely controversial. What are the resources, as Dr. Strain discussed in his presentation on psilocybin, where will the money come from? Where the resources will come from? Whom are we going to train? How are we going to train them? And what are the alternatives? And I also mentioned this in such a bad, grim, dark picture that you have little children and babies dying because their parents are using drugs. This is not right. With all due respect, it's a faux pas. So, and this is, it's too long, but if you have access to it, you can see it. This is something that actually was published about 6 years ago that explains very carefully why and how we need to consider involuntary commitment similarly to suicide. And lo and behold, I would refer you, the New York Times is probably the most valuable or respectable newspaper in the United States. And on September 2nd, Keith Humphrey, who is a colleague of ours, I don't know him personally, but he's a well-respected addictionologist, published in a newspaper that's relatively liberal and left-leaning about how important it is to consider forced drug treatment, especially for people who have some kind of cognitive compromised ability. So, you know, we can be very liberal and we can sing all our, you know, all our DEI and whatever stuff of liberalism. American liberalism is not European liberalism. But the bottom line is we need to save life. We lose 100,000 people a year. It is not justified. So in terms of what's happening in my little state, it's huge. By the way, again, that to show you how painful it is. In the state of Connecticut, the number of people who die from drug overdose is greater than the combined number of those who die from car crashes, suicides, and homicides. This is unbelievable. This is like through the looking glass. This is, you know, the slippery through the rabbit hole. These numbers are totally out of line. You can't accept something like this. And yeah, we are not doing very well, and we need to look for more ways to improve it. And that's about it. This is some recent publication of those of you who are interested in my line of research. Merci beaucoup. We asking question now or later?
Pardon.
En person.
There are questions in the room.
Thanks for the presentation. I'm going to challenge you about the civil commitment. And the question is, you mentioned the deaths of despair, which are generally characterized by a loss of autonomy and self-determination, people who feel like they have no more options and no future. You also mentioned the dissolution of families, the loss of parents either to death or incarceration as being a contributing factor. Isn't that exactly what civil commitment does? It disrupts families and it is the ultimate pulling away of autonomy. So I'm not sure how it helps.
Okay, first of all, I want you to know that this person is from Minneapolis, where I'm not from. I'm just joking. I'm not going to start the discussion now, but that's exactly what I'm looking for. I would like to have the discussion of nay and yay sayers, and let's discuss what, when, how much, and for whom. Otherwise, it's going to be a total pie in the sky. And yes, I'm very sensitive to these issues, particularly because I work with children and adolescents. And I think that sometimes, I know you're going to hate me for saying this, it's jokingly, but sometimes it's true. Sometimes parentectomy is not the worst thing when you are living with parents that might kill you, either intentionally or unintentionally. And I refer you to the article in Pediatrics. It blows our mind. It's unbelievable. 2,000 children aged 0 to 4 that perished because they lived with parents who have drug problems. This is unacceptable. There's nothing holier than life. So with all due respect to autonomy issues, we need to come with some criteria, similarly to suicide. How many times do I see in the emergency room parents who bring a kid, an adolescent, who is suicidal, and through the night they say, well, you know, we'll take him home. He promised he won't do it anymore. When they're in the ER, we're going to make the decision based on the criteria established. And of course, they threaten you with lawyers and everything. You know, in the United States, it's all about suing you here and suing you there, but that's why we need to have a good discussion and come up with criteria and then measure the outcome, see how many lives are we saving. There's ways to study it, and those of you here involved in medication trials, you know that you can predict how many depressions will be remissed or how many people will not die because of using this and that amount. So thank you for challenging me, but I'm not getting into this duel. I would love to have it, and the more controversy, the better, because it's important that everybody will have the opportunity to express their opinion, and then we will have to vote, and we will have to make a decision, and we'll have to follow the decision. So even in Minneapolis, and one day I'm going to visit you. Anything else?
Écoutez, je crois qu'on va s'arrêter là parce que le temps tourne.
I think that we will stop the discussion here. I have the question to you. I will ask it to you afterwards if we still have time, and I will give the floor to Mr. Maremannni, who will not be introduced. He will tell us about the low agonist opioid medication doses that kill. He will tell us how clinical caution fuels street overdose deaths.
Hello everyone. Sorry for my reading, but my English is terrible still now, so it's better that I read. The message I want to start with is simple but strong. Low doses can kill. When we give too little methadone or buprenorphine, patients are not protected. Instead, they are pushed back toward the risk of street opioids. This is not real harm reduction. It is not a safe medicine. In heroin addiction, under treatment is dangerous. It leaves people exposed, and it can lead directly to overdose and deaths. This is my disclosure. Methadone treatment has a long history that began with Dole and his wandering intuition. People with drug addiction should be treated as patients with an illness, not as offenders. They became famous for using high methadone doses, not to test a new therapy, but to correct an early mistake. When they tried giving patients as much morphine as they wanted, the condition worsened and tolerance increased dramatically. Only high doses of methadone restored the patient's clinical stability. This marked the real revolution, moving from detoxification to maintenance, but the dosage has remained the central challenge. So, what do we actually know after 60 years of methadone maintenance? First, we know that addictive behavior can be controlled with very different doses, not only for one patient to another, but even for the same person at different times in their life. Second, some people can be stabilized with less than 60 milligrams a day, but for most of our patients, the effective range is between 60 and 140 milligrams a day. Third, there are cases where people need much higher doses, sometimes up to 1,200 milligrams a day. And finally, there are a few patients who do well for life on just a minimal dose. even as low as 10 milligrams a day. To treat opioid addiction, we need to think in steps. We start with an anti-withdrawal dose, just enough to control the acute symptoms. Then we move to the blocking dose, which become the stabilization dose, protecting patients from relapse. After that, we enter the maintenance phase with the maintenance dose that keeps them stable over time. And finally, if possible, we can gradually reduce the dose until the medication is stopped. So in practice, we deal with 4 kinds of doses: anti-withdrawal, blocking or stabilization, and maintenance. This slide compares methadone dosages over the first 3 years in patients with and without dual disorder. During the first months, doses are slightly higher in patients without comorbidity, but from the 6th month onwards, those with dual disorder require consistently higher levels. Interestingly, at Q8, the disengagement phase is interrupted. Those rise again, returning to the stabilization range. The key message is that the dosage over time is not a straight line. It fluctuates, reflecting the patient's evolving clinical and psychological needs. Blocking doses are essential not only for stabilization, but also to protect patients from overdose. Think of the recent deaths in the United States and Canada during the opioid and fentanyl epidemic. Many of these lives could have been saved if the patients had been treated with the proper methadone blocking doses. Back in 1968, during the student revolution in Paris, there was a famous phrase: "Quand les doigts montrent la lune, l'imbécile regarde les doigts." And that is exactly what has happened. Faced with the catastrophe, policymakers have focused on distributing antagonists to drug users themselves, instead of ensuring proper treatment. But let me ask you, what is better, to bring someone back from death or to prevent death in the first place? Is the blocking dosage, therefore, the one at which the patient no longer feels the action of heroin? No, that is not enough for us. The first to make this very clear was Mark Reisinger, Vice President of Europad in Kyiv, Ukraine, back in 2012. He explained that what we often call a cruising dose, the one that stops withdrawal and daily heroin use, is only the beginning. Because dependence is not just inside the body. It extends to places, times, people, the whole environment. That is why opioid agonist doses must go further. They must protect against alcohol and drug abuse, against cravings, even against dreams of heroin, which are often a warning sign of a relapse. The true blocking dose is reached when the patient can say no to heroin, even when it is offered. We can ask, when is a blocking dose really needed and when is it not? It is needed when we want to silence heroin craving, but also when we want to stop high-risk behaviors like need sharing, infectious disease, or polydrug use. It is needed in pregnancy, where stability is vital, and it is needed in dual disorder, where the risks are higher. On the other hand, it is not always necessary if our only goal is to take away withdrawal symptoms or simply to help someone regain quality of life and social adjustment. If we decide not to use blocking dosages, or if the patient does not want the blocking dosages, then it means that we are doing harm reduction and not the treatment of heroin addiction. In this case, we move from anti-withdrawal doses of the safe induction phase directly to the maintenance phase with or without anti-withdrawal dosages. In this way, it will still be difficult to rehabilitate patients. Then we will arrive at the reduction of the medication without having achieved actual rehabilitation, and the consequence will be early readmission. Patients return to treatment less than 1 month after the latest treatment ends, almost in Europe and especially in France. This slide helps us to make a clear distinction between harm reduction and comprehensive treatment. Harm reduction can only succeed if it is not isolated, but fully integrated into the treatment system. In practice, this means a biopsychosocial approach, where drug addiction is addressed at different levels of intervention, biological, psychological, and social, working together. In this study shows that the opioid agonist treatment approach leads to better recovery and higher rates of abstinence from polyuse compared to the harm reduction treatment model, even though patients in agonist opioid treatment had more severe substance use, as well as psychiatric and physical comorbidities. These findings support the possibility of using lower maintenance doses of opioids, but only after proper induction and stabilization, following the Dole and his Wonder method. This is something that the current harm reduction treatment model does not make possible. What I really want to stress here is this. Dosage matters, treatment duration matters, but above all, completing every single stage of treatment is absolutely crucial. And this is not just a theory. It's something we already demonstrate in this landmark study from our group all the way back in 1994. If we look at our patients by treatment stage and compare them with those in harm reduction, the picture becomes clearer. In the first group, we have patients who stayed longer, had the proper stabilization, reached good levels of rehabilitation, and then gradually tapered their medication with a flexible plan. The second group are those on stabilized method of maintenance, following the program regularly and working with the staff. And then, in the third group, we find those who prefer rapid detoxification or who don't really share the philosophy of the program. Now, look at the data. People on very low doses, around 20 milligram, only show better outcome if they have first completed all 4 phases of the Dole-Innis-Wonder method. Without the full process, low doses simply do not work. In the past, we showed this very clearly. When seriously ill patients are kept on low doses of methadone within a harm reduction program, cravings for heroin and alcohol increase. And alongside that, we see higher level of psychopathology. So the lower the dose, the greater the suffering, both in terms of relapse and mental health. On the other hand, when Dole-Innis-Wonder full methodology is applied, as in this study, the results are striking. Cravings for heroin, for cocaine, and even for alcohol drop significantly after patients enter treatment. And this is achieved simply by using proper methadone blocking dosages. We have seen that the blocking dose must always be individualized. It's never a fixed number. And the same principle applies to stabilization and maintenance doses. From our clinical experience, we can say that there are full levels of stabilization, depending on the opioid that the patient is carrying at that moment. First, the severity of the illness and the level of tolerance to opioid in the street. Second, the possible presence of a pain syndrome. Third, the presence of psychopathology, whether specific or related to dual disorder. And fourth, the stress sensitivity of our patients. We don't have time today to explore stress sensitivity in detail, but it is something that must always be considered when adjusting the stabilization dose. To monitor our patients effectively, we must go behind the urine test and look at the whole picture. This means considering addiction history, psychopathological symptoms, craving for heroin and its behavioral covariates, reaction to loss and trauma, subjective wellness, and the severity of cocaine and cannabis use. In short, monitoring must be comprehensive, biological, psychological, and behavioral, because urine tests alone never tell the full story. If we also collect information about our patients' sensitivity to stress, we can see something very important. This study shows that the post-heroin stress sensitivity actually goes down as the stabilization dosage goes up. In other words, the way patients react to life events is not fixed. It's influenced and can be improved by the right opioid medication. The stabilization dosage also make a difference when treating heroin use disorder with the dual disorder. In this study, patients with a bipolar disorder were treated with around 140 milligrams of methadone, while those without dual disorder received about 120 milligrams a day. The outcomes were very similar. Both groups had good retention and stabilization, but notice this, patients with a bipolar disorder tended to stay longer in treatment when they were given the higher dosage. So, higher doses are not a risk. They are often the key to keeping patients in treatment. Now, let's look at the patients with the chronic psychosis compared to those without dual disorder. In this study, the average dose was about 150 milligrams for chronic psychotic patients and about 120 milligrams for those without dual disorder. The difference is small, not statistically significant. But there is one point to underline. Chronic psychotic patients tended to stay in treatment for a shorter time and on lower doses compared not only with the controls, but also with the bipolar patients. Still, notice this, all of these patients, psychotic, bipolar, and controls, were stabilized with higher than standard doses. And this tells us something very clear. The so-called standard low-dose treatments are not a treatment at all. They are a dangerous illusion. However, the highest dosages are reached in patients who in this study also had a strong benzodiazepine addiction. This tells us something important. When there is a polyuse, the need for higher blocking and stabilizing or maintenance doses becomes even greater. Polyuse does not only complicate treatment, it pushes the threshold of effective dosage upwards. Yes, the end. If you are not routinely applying blocking or stabilization doses, perhaps it is time to treat your own treatment system. The ancient Greek maxim, know thyself, apply not only to individuals, but also to healthcare system. A system that ignores its limitation cannot truly heal its patients. And let us be clear, to reduce overdose deaths, we must overcome our fear of effective dosing. Policymakers who insist on so-called low-dose safety are not protecting patients. They are failing them. The right dose at the right time is not a detail. It is a difference between life and death. In medicine, give too little, it kills just as much as when it gives too much. Our message is simply, addiction is a disease, and under treatment is not safer. It can be lethal. The Pisa School stands together on one point. Giving the right dose at the right time is not an option. It is our duty. Anything else is abandonment. Thank you.
At the end of the presentation or now? No, I'll have. So questions will be reported to the end of the session. I will give the floor to John Strong.
Bonjour, merci. C'est un grand honneur et aussi une occasion de renouer.
It is a great honor, and it's also the occasion to find old and new friends. So today I'm going to talk about the need to improve prevention and to try to detect and prevent opioid overdose deaths. As you may have observed, I do not master French. I'm not too fluent in French, so I propose that for my presentation, I'll switch to English.
Wanted to talk about some issues around detection and potential future interventions regarding opioid overdose deaths. In developing this work, patients and advocates and their families, as well as colleagues, have been a crucial part to developing this work. I'm grateful to the organizers for inviting me, and I'm a clinician and an academic, and I've worked with government departments and with different parts of industry in both the medication realm and the technology realm, looking to try and develop new interventions. And these are listed here for you to look at later on. So there's 4 areas I'm going to cover. One is just a minute or two about the undone science, asking questions about why we have not developed a better understanding of what happens around opioid overdose and overdose deaths. Secondly, a few minutes about the NALPAUSE study, particularly because we had hoped to be able to have a branch of the study here in the south of France, and the arrangements never finalized. It's a great pity. Then the third area to look at, can we envisage wearable devices which would detect the opioid overdose emergency? And finally, can we see innovations to improve the portability of the naloxone, which we wish to be carried universally? So first, the undone science. The area of looking at what one could do about overdose death is very much connected with the attention to HIV and our understanding of harm reduction initiatives, that we're not merely wanting to tackle aspects of somebody's substance use itself, but also in particular to look at the harms that result and how we might have interventions at an individual or a societal level that reduce those harms. If you are wanting to look at the issues around opioid overdose and drug overdose deaths, there's a very valuable book being released a couple of years ago by Nancy Campbell, looking at various aspects of opioid overdose, with a particular focus on North America, but also looking across Europe. Let me just spend a few minutes talking about the NALPAUSE study. We are in the process of analyzing the data at the moment, so I'm only able to tell you about the sample we've collected, and I'll need to present on a separate occasion about the key findings. First of all, an explanation about its origins. When the pharmaceutical company Mundipharma were developing their naloxone nasal spray, which is now in many of our countries as Nixoid, we had proposed to them that it was important that we filled a gap in the scientific literature about a prospective cohort study So to what extent of naloxone supplies provided, how often were they actually used, rather than relying on people returning with information where there's obviously a very selective sample. That was not initially supported, but in fact, when the company then submitted their product to the European Medicines Agency for approval, there was a requirement for a post-authorization efficacy study, and there was an opportunity for the university to negotiate with Mundipharma that we would do a prospective cohort study of individuals receiving any form of naloxone. So that might be the injectable form or the nasal spray. And that's how the study came about, and we would follow up the sample for 6 months. So for members in the audience not from Europe, we have two main products in Europe of naloxone products. We have a pre-filled syringe with 5 doses, 5 0.4 milligram doses within the pre-filled syringe called Prenoxad. And then we have 2 different nasal sprays, one at 1.8 milligrams, one at 1.26 milligrams. And these are the main products that are used in Europe. It's interesting to look at how these products actually vary. So the US, the main nasal spray product would be a 4 milligram nasal spray. There's so twice the dose of the Nixoid nasal spray and 3 times the dose of the Ventizolve nasal spray. And of course, in France, you also had Nalscu for a while, but I think you've not had that for a couple of years, if I remember correctly. So, if people are wanting to look at the detail, we have the protocol of the paper that's been published. I won't take you through the detail of it, but I'll just pull out a few points. So it's a prospective cohort. 1,400 people that we recruited to whom naloxone was provided across a number of countries. And we're looking at what occasions were there in that 6-month period where they were then present at an opioid overdose, and what actions did they take when that intervention opportunity arose. Fortunately, the split across types of naloxone was 50-50 between, approximately 50-50 between injectable product or nasal, but this was not by design. This was not part of the study. This was what clinicians were choosing to provide from the different agencies. So we would study people who were themselves using opioids and in treatment, also a sample of people who were not currently in treatment, and then also family members or friends, as well as staff working in relevant agencies. Our main focus is probably on the 900 people who were using opioids and were in treatment. We also had a sample of 123 who were not in treatment, and that's probably those are the 2 groups we're focusing on in our analyses at the moment. And just a few headline messages before I move on to other areas. That there was a very high presence of that sample in a 6-month period. 27% of them had actually been present at an overdose. So if we're thinking, is there an opportunity for an intervention? There was a very big opportunity. That was especially so amongst the out-of-treatment sample, where half of them were present at an overdose in that 6-month period. And we also found it reassuringly feasible to follow that sample up despite them not being in treatment programs. We'd been uncertain about whether that would be feasible. We did interviews with the sample, and we were quite impressed with what one would call their diagnosis, sort of correct diagnosis of the problem. and also the interventions they made were correct. As I say, that these information, we're still analyzing them at the moment, so I won't cover it any further. So let me now move on to talking about, could there be wearables? First of all, I'm in a fortunate position in my university that we have an experimental ward, a clinical research facility, where we can bring patients in to study all sorts of different medical disorders. And they've been willing for us to study small controlled heroin overdoses so that we can see what occurs when heroin is injected and how does respiratory function change. And there's a paper led by my colleague, Bashak Tash, describing how we have set up this laboratory model for heroin overdose. Here's a photo of the bizarre. It's like some mixture between an emergency ward and a space capsule. So we were not sure whether this would interfere with our ability to see changes in respiratory function. But as you'll see in the next few slides, we were able to detect very significant abnormalities, which have led on to our ideas of wearable devices. So here we have one of the individuals. Let's concentrate on the top two lines. Here's 3 minutes of their breathing pattern. And you can see on the top line, they're breathing at about 10 breaths per minute. And the red line beneath it is their oxygen saturation. And that's steady at something like 95%. So that's very reassuring. There's little to worry about. And then a few minutes after their heroin injection, you have this abnormal picture has developed where there's still regular breathing, and then there are prolonged episodes of no breathing at all for up to a minute. And the red line being the oxygen levels has become chaotic compared with the previous level. I'll come back to that slide in a minute. But this led us into thinking, with all of the Fitbits or Apple Watches that we wear, should there not be the ability to measure some of our physiological parameters to realize that something has gone wrong, to be able to send an alert signal via via Bluetooth to your phone, to your partner, or even directly to emergency services? This should at least be explored. And if you think of that trace that I showed you of those prolonged apneic episodes where there was no breathing for up to a minute, here's a signal that you would have thought was quite easy to find a way of detecting that there was no chest wall movement and breathing pattern. And that's what we're now currently studying. We're working with a small company from Scotland who've developed a prototype wearable chest sensor, which is a 3D accelerometer. I think the next slide, we have a paper describing the device itself, which people are welcome to read. It's quite a heavy-going paper about the device. And the 3D accelerometer shows the different movements of the chest wall as people breathe in and out. And so it's disruption of this pattern that one's looking for the apneic episodes. And we're in the middle of studying this at the moment. This would be how it would send a message via Bluetooth and send an alert to a partner. Our first study was with a supervised injecting facility, so working with colleagues in Australia, in Sydney. We were looking at people visiting the supervised injecting center. And with the numbers at the bottom, so we recorded more than 1,000 visits to the supervised injecting center. There were 80 visits where there was some clinical concern about whether the opiate injector was having problems, but for most of them there was not an emergency, but for 10 of them it was a full overdose emergency. And so we're looking at the clinical records and the traces from the chest sensor across those different episodes. And, we're looking at that at the moment. These are the sorts of traces that are detected. I won't go into the detail of the analyzing of them, but there's a paper that's just been published last week with some of these traces for people to look at if they want to see more detail. There's also a protocol paper about the next study we're doing, where we're looking at constant wearing of this device by people who are doing the study in a hostel for homeless populations, checking on drug use events amongst this population, and whether we are able to successfully detect when minor overdoses have occurred. We're currently analyzing those data, and I hope to get a result from my colleagues when we go back into work next week. Okay, finally, I just want to talk about some work we're doing around could one not have a much more portable version of naloxone. I imagine all of us are frustrated by the bulkiness of most of the naloxone products. I've met with companies producing it and they turn up with a little briefcase and somehow expect drug users to wander around carrying a briefcase with them, and it's not gonna work. Also an alert, I'm actually going to make you work for your attendance here. I'm hoping to ask you to, a little bit further, about a couple of minutes after a few slides, I'm going to ask you to scan a QR code and answer some questions to help us refine the decisions that we have to make. So we have a major problem with naloxone provision. Most countries, we have good distribution. So these are data from Scotland, and you can see over a 10 to 12 year period on the bottom, the dark bars are the improved proportions of people at a needle and syringe exchange scheme who've been given naloxone. So it goes from 8% back in 2012. We've now got nearly 70% of attendees have been given naloxone. So one would think that's good news, but the light blue bars are the proportion of people who are carrying it with them, and it's between 5 and 20% who are carrying their naloxone with them when interviewed. So the poor carriage rates is a major problem. We've done studies across Europe and found similar findings. So we had 17% of people across a number of European countries were actually carrying their naloxone at the time of interviews, even though they had been given naloxone and were strongly supportive of it. I'm also aware, in fact, I think we have Don DeJale here with us, and Don's done some work with colleagues in New York looking at similar issues. What can one learn about the different patterns of carrying naloxone? I think it's an area that we hadn't properly considered until the last few years, so we need to pay more attention. So we're looking at, could we change the product itself to address possible limitations of nasal naloxone? It was developed with healthy volunteers, all of whom needed to have intact nasal mucosa, must not have a cold, must not have hay fever. But we also need much more dose flexibility, particularly with our concerns about fentanyls and nitazines and synthetics. With colleagues in our pharmaceutical science department, we were able to show proof of concept development of a lyophilized, a sort of freeze-dried wafer of naloxone that appeared to be reasonably stable and would rapidly disintegrate on contact with the inside of the cheek in the mouth. And that led us to look at whether we could develop this further into a viable product. My colleagues in pharmaceutical sciences were able to test it for different temperatures, different degrees of moisture, and so on. And we've recently had government funding to take this work forward. And you will see a mock-up in the picture about what we hope the product would be, which would be a strip of 10 doses of naloxone in an instant dispersal wafer that would be credit card sized. So like a donor card, you just put it in your wallet, and 2 years later, when you're at the emergency situation, you suddenly remember, do I still have that naloxone that was given to me 2 years ago? I don't have time. I've got a video about what it looks like, but it's a credit card size in a wallet. We're now at the stage that we've we've shown the feasibility of manufacture. This was the actual first batch about 18 months ago, proving the stability of the product. And this is still on stability testing at the moment. And this was the batch for healthy volunteer study, which we're due to start next month, where we'll be testing the blood levels, looking at does it get adequately quickly absorbed and adequately efficiently absorbed to be a true competitor product for the future. We're currently at the point of needing to decide what do we think are the key parameters. And this is the bit where I'm going to ask for your help with some of the decisions we've got to make now about which parameters of the curve do we think are important and what doses do we think we should have. So if you're willing to help out with key decision-making we're needing to make at the moment, if I can give you a minute or two just to scan the QR code and give me your thoughts on decisions we should make for the future. And I'll let colleagues do that, and then I've just got 2 more slides. So maybe when somebody's finished filling in the questions, if they put their hand up, so I'll realize that you've had enough time. Well, I'll just leave it a few more minutes. Yeah, perfectly. I'll just do my concluding points while some of you are finishing those questions. So I think it's an area we've not pushed the science field fast enough to give it the attention that it deserves. It's a hugely interesting area, and I think for many of us, we realize what an area of undone science it's been that's and now so interesting to visit. And we should be proud of what we've achieved, but also humble about how much more there is that we still need to do. Thank you very much.
Merci, Sir John. La dernière intervention.
Thank you very much, Sir John. And the last intervention will be by Marie JAUFFRET-ROUSTIDE. She's going to tell us about Coquelicot.
Well, I will indeed present the last results of the Coquelicot enquête, the Coquelicot survey. Never unveiled yet, but I will also present the results of another survey. Marie JAUFFRET-ROUSTIDE, I am sociologist, researcher at NSR. I will tell you about the assessment of harm reduction in France progresses, but populations that face discriminations in healthcare. I thank all the ATHS team. It's always a pleasure to attend this conference, and we have the possibility to meet some actors in the field and concern people. First, a few presentation elements about the French model on harm reduction. We talk about overdoses, and this slide is echoing to compare the North American situation. I will come back to that afterwards because we undertook works with Honora Englander and Benjamin Roland about the comparison between the French model of harm reduction and the American one. France has a policy of harm reduction in the law of health 2014. This characterizes also the French situation is that unlike the States, harm reduction is supported by public fundings vis-à-vis the United States, even though they could be more, taking into account the augmentation of people who attend these harm reduction services. But compared to the States, we have a constant and public funding system allowing an access to harm reduction on a free basis and available over the whole territory. This model includes a medical approach of addictology, but today I will focus on the TAO, a biomedical approach characterized by a huge accessibility to the opioid agonist treatments available in France in 95 for methadone and since 96 for buprenorphine. There would be thousands of people OAT according to the data of 2023, the data from the European Agents of Drugs. In my presentation, I forgot to mention that I was a member of the Scientific Council of the European Agency of Drugs. And these data go from 2010 to 2022. Very clearly on this slide, we can see to which extent France, in comparison with to other countries such as Germany, to which extent our level of agonist treatment is higher than in other European countries. I will tell you about overdoses with data of the European Agency of Drugs. The overdose part, the number of cases per million inhabitants is, well, in blue, the more the blue is light, the less cases we have. Less than in the UK, as it has been presented by Sir John Strong, as well as the Northern European countries which are facing an increase of opioid augmentations. How to explain so far the absence of crisis of opioid overdoses in France, where we undertook works with Honora England, Benjamin Roland, and the team of Hospice Civil de Lyon. Last year, we led interviews with Honora to try to understand the differences between the States and France, trying to understand why so far France seemed relatively protected. There are some assumptions. The drug market is different in France. Fentanyl is very little present in France. There is the existence of a safe supply in France with the presence of an illicit market of morphine sulfates. This is a protecting factor which is very important regarding other countries. we have an accessibility of the ATHS, so buprenorphine and methadone prescription in city health centers, as well as reduction of harm reduction in buses of low threshold. They are less submitted to urinary controls. The prescription rates are prolonged to facilitate the social life, and there is a framing and saving of opioids, which is guaranteed by the National Agency of Drugs. Publicity is prohibited in France, and there is strict watching of the conflict of interest. This works completely with Benjamin Roland and Glenda. We launched the 4 program with several international and French teams. We will do more in-depth surveys to try to understand whether France is prepared or fragilized. I will tell you some elements about the enquête Coquelicot, this Coquelicot survey. In the comparison between France and the States about overdoses, I told you of the works with Honora, but I also did works on this matter with other North American colleagues, Max Tigo and Gemini, as well as Jimmy Zelang and Elena Hansen. And we published these works in American Journal in 2022, comparing the access to buprenorphine in France and in the States, which is characterized by the curve in blue, the blue line, and the evolution of the overdoses in the orange line. When we compare France to the States, differences are really big, and we can see that there is a parallel evolution of the access to treatment, opioid agonist treatment, and the evolution as for the increase of overdoses in the States, in France at a very low level, whilst we have a high access to buprenorphine. The French success of the prevention is linked to access to methadone and buprenorphine, but not only. What we've studied, we have proven that this success was linked to the model of a welfare state existing in France in comparison to the state, which favors the harm reduction with the objective of the state to protect the most vulnerable people. I presented you the French story, the French success. Now I will tell you about the fragilities of the French model. France combines this healthcare system as well as a prohibitionist regime. Drugs are forbidden in France. Criminalization of the drug users is important, and we can see that harm reduction is a complex situation. We can see it with the implementation of halte soins addiction. It stopped in 2025. Many cities wanted to implement this regime without achieving it. We published in American Journal of Public Health to understand how the prohibitionist model made more complex the setting of consumption or use rooms in France. Beyond the works in France and Europe, these works show that prohibition has a negative impact on fundamental rights of the users. Access to health and social inclusion of people is limited by prohibition because they fear to be arrested by the police. This limits their access to healthcare, augmenting their exposure to infectious risk. And due to this prohibitionist regime, the drug users were more legitimate to feel they could be cared of. I move to the enquête Coquelicot. It is a survey of multicentric zero prevalence with time location sampling, including the generalized method of sharing weights, inclusion criteria, any drug users with injections or sniffing any substance, having smoked cracked at least once in their life. Well, these 2,125 were recruited in 195 structures, or companies or entities, CESAPA, CARUD, as well as many others. We replicate this survey since 2024 with the goal of assessing the policy of harm reduction. Here are the results of the Coquelicot survey. As it was announced, it is unveiled today. One of the worrying results of this enquête Coquelicot is when people refuse to be cared, to receive care. In 2024, well, in the edition of 2011, there were difficulties to obtain syringes, and in 2011, we had 30% of users participating who attended the CARU, and this instances, well, they noticed they had difficulties to have access to the syringes, and now we have added some questions about discrimination in the use of syringes. We have 24% of users declaring that physicians didn't want to prescribe this. 24% say that the pharmacist didn't want to supply OAT with orders. 15% refus de prise en charge by GP. 4% refus de prise en charge en SAPA, and 3% refus de prise en charge, so no medical services administered. We include populations which are included in the care and harm reduction. And we analyzed in a multivariate analysis which were the associated factors as for refusal to cover, refusal of treatment. What analysis showed was that these factors were having been injected, having lived or faced trauma events, having suffered discrimination, having consumed crack during life, having been in hospital in psychiatry, or having had an overdose during their life. Beyond the Coquelicot survey, I wanted to illustrate this question of refusal of treatment with another survey that we've done for Médecins du Monde, the impact of criminalization in the access of treatment. A qualitative survey in 22-23, and in spite of the harm reduction in the law of health of 24, this is a fragile law, and within this context on prohibition favors the discrimination of substance users. This discrimination in treatment from the quantitative data of the Coquelicot survey. In this new approach with the Médecins du Monde during the same period showed that access to syringes is sometimes difficult even in larger cities. One of the explanations of this access to treatment is the change of generation of professionals who today are less impacted than we were. Professionals who worked in the 90s due to the AIDS hecatombe, the AIDS pandemic. Well, in my life, it is a quote, some pharmaceuticals were working with CARUD, with health center, and now with the new generation of people, these new generations didn't want, I will say it brutally, they didn't want to see docs, a drug user in the pharmacy. As a professional of CARUT, I was very astonished. We are not supplying these syringes. So there is this feature of drug user that provokes, that causes fear in pharmacies. Some are comforted with the data of the European Agency of Drugs showing that syringes distributed in France only cover half of the needs. So half of the injections are not done with sterile syringes. These data show an important stigmatization linked to the use of drugs, and some works by sociologists and psychosociologists have shown that links between stigmatization and health are very strong. Stigma is at the base of inequalities. Stigma fuels isolation and adaptation problems, etc. On the other hand, stigma negatively determines the attitudes of health professionals who will be reluctant to treat, or they will treat them in a wrong way due to this stigma. And some patients, addicted patients, will keep silent their problems of health. They will limit they will not require the services because they don't want to be stigmatized. Our researches, whether they are quantitative or qualitative, highlighted that criminalization of drug users make the life of these users more vulnerable. As for the discrimination and stigmatization, these discriminations concern some people, drug users, injection users, people with psychiatric troubles, well, people from some ethnias, well, there are stigmatizations that fuel these discriminations. We can say that today French model of harm reduction and prevention of overdoses is getting more fragile. 1 out of 4 users have experienced one refusal of treatment, even with prescription. To preserve our French model of prevention of overdoses, we need to better train the health professionals, facilitating access to OAT and naloxone, and setting also alternatives to prohibition, and putting an end to the stigmatization of drug users and the discrimination in the treatment. So also acting on the structural causes of stigmatization. I want to thank all the substance users and professionals who participate in this survey, Martin Audrin for the analysis of the surveys, and Oviat for collaboration impact of this survey at Médecins du Monde. Thank you very much for your attention. Well, I am a bit worried because It must be, I think, yeah, it is almost 11 to 15 to 11, so a quarter to 11. So what Marie tells us, we are going to take some questions. Are there questions in the room? Yes, I can see an arm raised, at least one.
Thank you very much for your presentation. I was getting more and more worried by your presentation. I live in a rural area, and I thought about many of the patients that I support, and I believe that I'm quite unable to prevent OD risks, because some patients, well, they don't want to increase their treatment. I think of patients who take methadone in the morning before going to work, and they take heroin at night when they come back to work. And certain people refuse to increase their methadone. And I have observed as well that heroin is getting stronger. And my patient is alone, and in order to access naloxone, well, you need to be two people, and this person is alone. So I was very interested about the sensor that was described by Sir John Strang, because for people who are alone and they have trouble to access naloxone, this could be so helpful. And a second thing that I would like to mention regarding the Coquelicot survey, well, sometimes we do not have the budget to have enough risk reduction material. You were talking about syringes, but there's all the rest of the material. So thank you very much. So do you have a special question, actually a precise question? Yeah, it's actually about the isolation, how to reduce overdose risk for these people who live on their own. Well, they're on their own, but I think that there are many elements. I think that, as it was mentioned, there are these technical tools, as Sir John Strang proposed, but there are also many programs to support injection. And in rural areas, you can put in place these programs called early programs. Sometimes, you know, there are certain colleagues who are specialized in this kind of questions. And this kind of early programs can take place in rural areas. And sometimes there are larger programs for cities, but there are many programs for injection support. I think that actually, well, we have here another specialist in the audience of this kind of program. So I think that it would be excellent to exchange with this person.
There are different challenges for people who live in rural locations with many medications. You know, if you have emergency services or a defibrillator for a heart attack, but that is why we should look at products which are much simpler for people to carry with them. So like the EpiPen, you need special attention if somebody is in a more rural location, but if it can be carried with you, it overcomes some of that disadvantage.
So related to that question, John, I'm not so sure innovation needs to be stepwise. It can skip steps. Can you talk about why you selected an open loop detector rather than a closed loop that just automatically delivers the naloxone via the sensor?
I guess one is the ease of the challenge. To have I also think it raises more ethical issues and more anxieties that if you have a closed loop where it might automatically administer an antidote, I think there would be much more anxiety from the user community from it accidentally being triggered, or even triggered when somebody was moderately intoxicated, but not in what they considered to be an overdose situation. I also think it'll be important for wearable devices to be controlled by the individual user themselves. And there have been interesting discussions with colleagues about who should decide at what level of oxygen levels or what level of apnea an intervention should occur. And I think it very much has to be for the individual themselves. But many of my colleagues think that they know best and that they will decide when it should occur. And I don't think it'll work. People will not accept a device that somebody else has chosen how to set it. And that same issue is true for all of the devices that we have on our phones and our watches. If somebody tells me to go and do exercise, it won't work as much. In fact, won't work at all anyway. But it might work if I was choosing to set it and to put those in there. That would be my own thinking around it. So.
John, I would like to ask you a question. I'm an adolescent psychiatrist, so the term developmentally informed is very important. So my challenge to you is, from the perspective of developing adolescents, what message are you sending to young people who say, no big deal, I can always have my naloxone. If I think that something goes wrong, I'm going to use this damn thing. Excuse my French, as we say in America. So the issue is, have you done, or hopefully you will do, I'll throw you an idea, and do it in the randomized trial even, ask your client, your patients, what has changed in their perception if they would like to be on methadone maintenance and try to control or even stop using drug, because otherwise we get into the studies that, Roger Wise, Hillary Connery is studying, and myself, this suicidal tendencies. And I went to a rock and roll concert. Everybody knows who Iggy Pop is. And I think that rock and roll poetry is important. And he was singing, "We're all gonna die, so let's get high." And everybody said, yeah, So this is a cultural issue. Yeah. And developmental as well. Thank you.
Yeah. I mean, I think the whole area of interventions to prevent the harm of an overdose with the damage the overdose causes, and then especially for an overdose death, raises much wider questions. There is a lot of concern in the public debate about might it increase risk-taking behavior, which I think is part of what you're referring to. And there's very little evidence of increased risk-taking behavior, but this same phenomenon exists with all risky activities. And there's a literature about risk compensation. And there is a degree to which we take greater risks because of the greater safety around us. I'll choose two examples, one being seat belts when you're driving a car, or with technology of improved brakes. We do drive cars faster and more aggressively because of those technologies, but the overall benefit is still much lesser accidents. And the other example is with skiing and snowboarding to do with wearing helmets. There are people ski more aggressively when wearing a helmet, but there are less serious injuries. And I think we have to accept some of those uncomfortable areas, but it does mean the wider debate, both for the users themselves and for family and the society, are part of what we have to engage in. And that's similarly true for needle and syringe exchange schemes and for treatment programs, but it makes for a much more interesting debate.
Next time.
Bon, alors en fait, je voulais vous poser.
I wanted to ask a question, but actually I think that time is, well, we're out of time and we're going to close the session. And I hope you have a nice break. Thank you very much.